is I find that the spinous process of the caudal, which in this case is L5, is always in the way of our Harrison punch going to the contralateral side. So I tend to trim it very early on in surgery. Actually, I either use a burr or osteotome depending on the size of the caudal lamina, the L5 in this case. I do it as early as first 20-30 minutes if it's a very narrow interlaminar window. That creates a good window for me to reach the contralateral side. So I think for Professor Zhang Wei's case, this time doesn't need that because we can see that he managed to decompress the contralateral nerve root all the way to the axilla without removing the top part of the L5 lamina. But for some of my cases, I need to do that. So this is one of the slight difference in what I do in the surgery.
Okay, so thank you for your comments. So may I translate in Chinese? Maybe some Chinese colleagues. Okay. 刚才我问一下 Dr. Wu，新加坡的吴教授，他的意思就是他可能对处理尾侧1/5那个棘突根部减压对侧的时候，他还会要模杖啊或者其他的工具做些处理，才能更好的处理对侧。张伟教授这个呢，他没有在这方面做很多的处理，也可能这个病例可能相对来讲对间隙的高度还可以。那么所以我的棘突就是说棘突的根部的过顶的时候。1/4肯定是要处理，1/5有一些病例是还是需要处理。Okay, thank you very much. So Dr. Kaki, what's your comment?
Oh, thank you. I'm happy to see wonderful surgery of Dr. Chang Wei. I want to talk about one case I experienced massive bone reformation after sublaminar approach. I mean restenosis by a massive bone reformation. Have you ever experienced reformation, restenosis with bone reformation, doctors? Have you experienced? If you, yeah.
Restenosis.
Yeah, by many bone reformation. I want to know how to prevent bone reformation by after the first surgery. I want to know, do you have any plan to preserve restenosis?
So any experience from the Dr. Liu? Do you have any experience?
至于他是什么，我听得迷迷糊糊。
他就是说他restenosis, how to prevent restenosis after the first surgery. So he's in future.
Yeah, I experienced one case of very big, very massive bone reformation, and suffered restenosis.
Yeah.
Only one case.
Yeah. It's very interesting.
Can I make a comment because I have actually a pending publication I've already submitted for this kind of phenomenon. I do both uniportal and biportal, so that paper is on uniportal LEULBE, bilateral decompression. So we find that there is quite a number of restenosis, although clinical significance, they do well even with the restenosis. So we find that there are a few factors that lead to restenosis. One, if they are severe stenosis to begin with, compared to those with less severe cases. Second is if they have a hematoma formation. So that what Professor Zhang Wei say, we need to be very careful with not having hematoma. And that case, I feel that in general, they do form some remodeling of the bone. The SAP, IAP that we resect, they do have some remodeling. But I think the control of the blood clot is quite important. And hence, we find that in our cases, if they have blood clot, I think in general, they have more likely restenosis. And if they have a intraoperative complication, for example, a dura tear, and they also have a higher risk of stenosis. But I find that dura tear may be a confounding factor because patients who have very tight spine, very severe stenosis, almost the dura sac is it's so compressed that it's very minimal left. They tend to have a higher risk of dura tear as well. So I think it might be a confounding factor. But those who are very tight, I think we need to advise the patient that there might be a chance of stenosis. I hope that answers some question. I submitted for publication, but it's quite a lot of revision and quite a lot of questions. They asked me. It's not a huge number, as you can know.
Yeah, it's a very good answer. I think it's a very, there's no, I think no publication yet. So very few studies. Okay. So maybe in the future we will need to, to focus on this very interesting question. So thank you for your question, and also thank you for your experience. So Dr. Zhang Wei, now you start.
This is a second case. Second case have been introduced by the Dr. Liu Zheng. This is a right side case, but I choose the left side approach, the contralateral side approach. The left side is the cranial side, and the right side is the caudal side. And above is the midline. Below is the surgeon side. We can see the L4, the low margin of the laminar, and the upper margin of the L5, L5 is the laminar. This is L4's spinal process.
这个张伟刚才就解释了一下方位，然后他说是这个病人右侧病变啊，但是他从左侧路来做手术啊，9点钟是头侧，3点钟是尾侧，12点钟是内侧，就是中线，然后6点钟是外侧，就是左侧啊。这个他这同时写入了1/4的椎板下缘，这个是1/4的椎板下缘现在起膜的，那刚才1/5的椎板上缘他也稍微写入了一下的。
No, I will make sure the right level. So I will do the X-ray to show the bone is located in the junction of the spinal process and the laminar.
要透视一下是吧？
对。
透视看确定一下脊柱椎板交界处。
朱成月把那个透视的那个定位的那个模钻定位的那个地方给大家拍一下，这个定位的这个地方就是一开始对，就是一个模钻定位是这个给大家放到群里看一下。Then I will to use the X-ray to confirm the spinal process of the L5, because I will do the translaminar approach. I want this point is located in the low margin of the L5's pedicle, because the disc fragment is go downward to the low margin of the L5's pedicle. You can see the ligament between the two spinal process. I make thin the lamina of the F4. The basement of the spinal process is the key, is the door to the contralateral side. If I want to see the contralateral side prominal area, I must remove more the bone of the lamina until the level of the low margin of the pedicle of L4. You can see the inner plate of the lamina. I use the detach to detach the. I will find the space between the laminar and the flap ligament. Now we can see the midline of the flap ligament. I will do another X-ray to show the ball is located under the medial margin of the L4 pedicle. Because the exiting nerve root is under the medial, the lower margin of the L4 pedicle.
Professor Zhang, when you do contralateral approach, do you use a slightly lower viewing portal, lower portal in general?
Lower portal?
That means we go a little bit lower, both the viewing and.
Yeah, yes. For if I for this case, because the disc fragment is gone downward, so in the same time, I will to do the decompression of the contralateral side terminal. I think the work portal is more lower. More lower is good. This case is very interesting, but for majority of the case, the disc fragment will go to the up direction, but but for this case is go downward. But there is also a disc fragment in the terminal area. So for me, it's difficult for me to remove the contralateral side up margin of the L5. So I need the Johnson portal to remove the contralateral side of the upper margin. This is the first time for me to use the Johnson portal in the living surgery. That's what now we can see the insertion, the proximal insertion of the flap ligament. You can see the contralateral side flap ligament. This side is also a very safe side for the beginning of the birth, because there is no cleft between the two flap ligaments. So I recommend you to start the birth from this year, or from here. The direction of the bore is medial margin of the contralateral L4 pedicle. You can see the pulse of the CSF, so I don't think there is enough anesthesia. especially the deep anesthesia.
Sorry, can you say tell us again? When you think it's not enough anesthesia, then the Durasec expand more. Is that what you're saying? I'm sorry, I didn't catch that, Professor Zhang.
So I will ask my anesthetist to do the deep anesthesia.
Okay.
You can see the proximal insertion of the flavor ligament of the contralateral side. This is a young man, so I think I hope to remove the disc fragment totally. But for the elder patient, maybe the disc fragment is difficult to remove totally. And another difficult one is for this case, you can see the X3, the lamina of L4 covered the whole disc space. So it means that we must do more bone work to get the abdominal area. The low margin of the lamina of L4 is below the distal space.哎，小朱，想着把几个定位的术前定位的图片给大家发一下，发过来啊，好。 So you can see for this area, it's not a good choice. We check again by X3.
Lo lamento, no pensé cómo te sentirías cuando dije que eras muy pequeña y yo... Pequeña no es bueno. No, ser pequeña es
张伟，
bueno.
你让朱成业把那个片子发进来呢，或者台下的呢？
好好，
发到那里面的，张伟。
那小朱，把我们复试的那个对侧定位的那个发一下吧。往上是对侧磨钻磨到哪了？磨到这儿。不是，还得磨到这儿，往上这推，这个哎。This is a low margin of the contralateral side of the laminar. Now I decided to expose the distal insertion of the flavor ligament of the apsilateral side. You can see this is apsilateral corner area. There is a narrow space between the IEP and the spinal process. So I remove the tip of the IEP.
Dr. Liu?
Hi, here.
Maybe some audience is just arrived, so maybe you can introduce the case one more. So
English.
Yeah.
English. Oh.
Okay.
Okay. Wait a minute. This is a 40-year-old male patient. His chief complaint is the right low limb pain. And MI shows a downward disc fragment and foraminal disc herniation of right side due to ruptured disc in L4-5 level. And Professor Zhang Wei's operation plan is UB foraminal decompression by contralateral sublaminar left approach, and UB discectomy by contralateral translaminar and transportal for the third incision at the right side. 就中文我再说一下吧，那个有些中国医生有些中国医生可能刚来。我们今天张伟做的一个是40岁男性的病例，他主要的核磁的主要的影像学表现，他症状是右下肢的放射痛，他核磁的主要的影像学的表现是右侧145椎间盘右侧突出，右往上游离，右往下游离，往上游离到145的椎间孔区域，134是145对145往上游离到145 134了，快接近145椎体的后方了，后下缘了，往下也有游离到155椎体的后上方。然后张伟做的是从左侧进去椎摆下路路，我觉得应该是进椎摆下路最主要掏的是往上游离的椎间盘，然后他还做一个第三切口，右侧的第三切口掏的是往下游离的椎间盘，做一个这么一个路路，这样的话避免对侧的关节突3、4跟4、5都避免去除过多，而且把往上跟往下游的椎间盘都能摘除干净。这还是比较一个特殊的路路的，用的是30度镜子。我看 Professor Zhang，
刘总
，Do you rotate your mirror Your endoscopy rotated.
Yeah.
If it's lateral side or contralateral side.
No, I rotate the. You can see the error of the endoscopy. This is the apsilateral side, the upper margin of the lamina of L5. Then I rotated the endoscopy. You can see the basement of the spinal process of the L5. I only remove the little flap ligament of the apsilateral side. But I will remove the whole flap ligament of the contralateral side. No, I do the bone work of the basement of the L5 spinal process. You can see the spinal process, the upper part of the SP of L5.
张伟，你再说一下吧，给中国医生。
现在我是因为是做对侧入路嘛，我同侧入路只是切除一小部分黄韧带。现在我在磨的是腰五的棘突的上半部分，上部。这样呢，我主要是做的是对侧黄韧带的一个整块的一个切除。这样呢，我的突破点呢，首先是从下位的腰五的这个腰五的棘突基底部还有对侧的这个下关突远端，我来建立一个第三通道就是我的那个Endoscopic。因为我认为从同侧来监视的情况下，这个对侧的下关突远端还有下位的棘突之间这个间隙是建立第三通道的一个非常好的一个间隙。现在我就是通过对侧的第三通道来放置第一级导杆。I will show how to build the third portal. You can see I insert the dilator through the contralateral side Johnson portal. The third portal is located between the IEP and the spinal process. Then I use the radio frequency to clear the soft tissue on the contralateral side of the lamina. You can see the contralateral side L5 surface of the lamina. Because it is difficult for us to remove the upper margin of lamina in the contralateral side. So I choose the third portal to remove the margin, the lower margin, the upper margin of the lamina.
我再给中国的医生翻译一下吧，可以啊。
我们因为我们这个病例是对侧，它往下游离的，所以我们需要切除对侧的下位椎体的椎板上缘。但是我们经过同侧的操作口呢，我们目前来说很难通过一个非常好的器械来去切对侧下位椎体的椎板上缘。所以我这个病例呢，我就附加一个第三切口呢，来去切除对侧的椎板上缘。因为这是也是有一个往下脱垂的一个情况的。
这个我再解释一下，可能有些中国医生刚上来，对，刚上来。现在那个张伟用的30度镜子，现在像张伟磨的是腰部的棘突的上缘的一个靠近。
上缘，对。因为我需要去也同时增加一个同侧的操作口的一个工作空间，所以我也需要磨一下棘突。因为我的整个定位点呢，就跟那个吴教授说的是比较偏下的。为什么？我为了减压对侧的椎间孔区域，所以我定位点比较偏下。但是我还得用这个同侧的操作口的话，我得需要把这棘突基底部磨出一部分。
其实你再说一下吧，给大家解释一下他的手术策略，因为好多人不能看到。
对，这个病例是相对比较复杂的病例，因为右侧椎间盘往上往下都游离突出，然后所以张伟从左侧进去呢，掏那个椎间盘，可能从往上游离的可能比较方便掏到，再往下游离呢比较难掏到，所以张伟建了一个第三切口，在对侧 右下方接了一个地塞切口。地塞切口呢，但是也不是说地塞切口马上就能掏到往下游离的椎间盘的，我们还是要把药物的棘突啊，这个上缘打包之后，把药物棘突的这个地方去掉一部分，来把对侧的药物椎板上缘再去掉，这样的话方便取右侧往下游离的椎间盘。现在的方位的话，还是9点钟，现在的方位还接近真实的方位的。9点钟还是头侧，3点钟还是尾侧，然后那个12点钟就是右侧，就是中线区域，6点钟方向就是左侧区域。
现在我在切除对侧的黄韧带，
对侧的黄韧带，对，取的是对侧的黄韧带，主要是就右侧的黄韧带，对，
因为这个游离的病例呢，它是偏中央的，它并不是偏一侧的，而且是游离也是稍微偏中央一点，所以我们可能会去把神经根显露出来，再去往中线这里牵拉一下。
我的理解是不是我觉得像这个病例啊，如果不是往中央突出，如果是后外侧突出的话，我觉得左侧路也都能完成，往下游离也能完成。是不是第三切口对中央型的往中央游离的病例可能会更有优势一点？
对。
第三切口对侧右侧进去掏中央的椎间盘更优势，因为我们从左侧进去掏游离到中央的椎间盘，从左侧的切口进去，然后从右侧进去掏中央的椎间盘很难掏得到。
是的。
所以这第三切口，我觉得这个是第三切口的优势，对这个病例。这个。
So, any comment for the surgical strategy? So, any other surgical plan?
Complicated case.
I mean, if you use UB, maybe it's very complicated. If you use monoportal endoscopy, maybe it's easier. Okay.
I do not know how to do this case by uniportal.
by post-lateral approach for uniportal endoscopy.
我因为刚才片子我没仔细看啊。
我发给你。
Okay. So we can discuss. I know it's a challenging case. We can preserve the more facet, use a contralateral approach. So it's good. But we maybe have another operation for the surgical plan. I will see. I will talk a little about later. Okay.
你来为大家介绍一下，在哪了？这个在哪？ This you can see this is the facet joint of the contralateral side. You can see I use the piercing punch by the transporter to remove the up margin of the laminar of contralateral side. I detach the superficial layer of the flavor ligament on the surface of the contralateral side laminar. If the disc fragment is not in the central part, maybe now we will see the disc fragment, but now we see nothing. So I will retract the dural and the nerve root.
So, Dr. Zhang Wei.
Okay.
The audience from maybe from the South America, Dr. Oliver Mudd, why don't you choose ipsilateral approach for UB this patient?
If I choose the ipsilateral approach, maybe if I wanted to do the decompression of the double nerve root, maybe I will remove the whole facet joint. Then I can do the decompression of the double nerve root. So maybe I choose the contralateral side approach. I can preserve the facet joint. Only the decompression, no the fusion procedure.
Okay, so maybe they don't see the case. Okay, this patient also had the foraminal disc herniation and also the downward fragment. So if you do the ipsilateral approach, you need to remove too much facet. So Dr. Zhang Wei, choose the contralateral approach to preserve the facet, and also to take the foraminal disc fragment, also the downward pressure the downward fragment. OK， 这个我用中文也再说一下吧。这个病例呢，可能刚才有些那个中国医生呢没有看到这个病例，它是一个145的一个，它在椎间孔区有突出，然后呢，那个同时向下游离是到155的椎中根的大概到下缘，所以呢，这个呢，而且还比较偏中央，所以张伟教授呢，他用的是这个就是对侧入入，他是病人的症状在这个右侧，他站在左侧啊，然后从左侧做切口，然后做到对侧，那么切除了一部分的棘突左侧的一部分，然后主要是做对侧的，右侧的，完了切完以后呢，这样可以斜着进去到这个椎间孔区，同时呢处理这个用第3切口呢处理这个向下游离的这一块。OK， Thank you。对，刘正，你可以把那个片子发到那个群里嘛，可能有些人能看到一些。
没有发了，我刚看有可以发，现在马上上传成这样。
OK， So， 但可能他那个嘉宾能看到那个 the guest can see the case, but the audience maybe not. So Dr. Zhang Wei, maybe another choice, maybe for this patient, maybe the transforaminal approach for the mono, so-called mono, or we call full endoscopic.
But I think it's not a good choice for the central disc herniation if you use the transforaminal approach. If you use the transforaminal approach, you only can do the decompression of the foraminal, but it's difficult to deal with the central disc herniation.
Yeah, I agree with you. It's challenging, but we can do it. OK。这个呢，我要再说一下我的个人观点啊，就是说这个可能张教授选择就是双通道，当然其实说如果咱们做椎间孔镜啊，就是说单通道，这个也是从一侧的椎间孔进去处理椎间孔的突出，同时做这个游离也应该是可以，但是呢确实有难度，因为对中央这部分的突出掉得比较远，你有可能需要切除，甚至要切除一部分的椎中根啊。对，但是这个我觉得是一些不同的方法啊，大家这个根据自己的掌握的技术啊，然后呢选择自己的擅长的技术，我觉得都是可以讨论的嘛，是吧，张伟？
对，椎间孔镜呢，可能得往下去来处理这个游离的间盘，但是它也可以去移动到上方来处理椎间孔区域的一些病变，可能是这是它的一个处理的一个策略，但是往下去掏除的话，对于老年人来说的话，这种间盘碎块比较碎的情况下，可能不是一个好的选择，可能会残留这种残留碎块的这种可能性。
So another question from the audience, also Dr. Overman, what about the paraspinal UB approach to preserve facet joint?
Because 您说那个谁？
没有，这个可能他没看到这个病例啊，就是你说一下，没关系，问一下他。OK。
Because for this case, there is also the foraminal lesion. So if only the disc fragment in the central area, I will choose the ipsilateral approach. But for this case, there is also the foraminal area lesion. So I try the contralateral side approach. this small size radio frequency produced by Bounce company is very useful. I think it is a curved one. No Bounce company have produced the adjustable radio frequency for this type. I think it's very useful for the UB-ACDF procedure.
Yes. Okay, Dr. Liu had some experience for cervical spine. UB assist the ACDF. Can you talk about that, Dr. Liu?
Frankly speaking, it's not UB SDF, it's MOEA SDF. Many open endoscopic assistant SDF. We perform the decompression under endoscopic monitoring, especially decompress the posterior longitudinal ligament and posterior disc, posterior osteophytes at the vertebral body, posterior vertebral body. We will got very clearly view in operation on the C-line drainage, C-line aggregation.
No, I remove parts of the upper margin or the laminar of contralateral side by the transporter.